Hello, everyone, and welcome to Living a Life with Loeys-Dietz syndrome with Dr. Bart Loeys and Dr. Hal Dietz. My name is Angela Christ. I'm the director of the Loeys-Dietz Syndrome Foundation and the director of marketing for the Marfan Foundation. And I also want to introduce you to Susan Lushin, who will be chatting in the chat box today. Providing some resources or possibly answering questions. If you have any questions for either doctor or both today, you can drop them in the Q&A, but we will be hanging around both areas to make sure we can get you as much information as possible. Welcome. This session is in the last time slot of our final week of the International E3 Summit, where we are educating, empowering, and enriching our community. This has been brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement, along with our partners in Europe at BESCERN. You are part of a history-making event where we've had nearly 3,000 registrants now from 72 countries, and we hope you found great value in this time, both educationally and in connecting with other members of the community around the world. It's certainly been a rare and exciting opportunity, and we hope you have enjoyed it and will continue to, as this session and all the others will remain in recorded form in the app and on the website, at least to the end of the year, if not longer. So we'll be communicating more about that in the future, but please continue to check in and use the resources however it best serves you. We would like to say a huge and final thanks to our presenting sponsors, Brigham and Women's Hospital and American Communication Construction. And a note that the International E3 Summit excuse me, is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of these talks, I'm so sorry, I got a little frog in my throat, are those of the speakers and not necessarily those of the Marfan Foundation or BESCERN. If questions arise or if you would like clarifications, please do reach out to marfan.org/E3ask. And we do ask for your patience as the volume of questions at that URL has been high, which is wonderful because we want to get lots of answers out as quickly as we can, but it may take us a little bit of extra time right now. Finally, before we get started, I want to ask that each of you complete a survey of this session as you complete it today or whenever you watch it, whether it's live or recorded, by clicking the rate button. It's just to the bottom of the window where you're viewing this presentation. It will be less than a minute and it will provide just truly exceptional information for us to make decisions in the future about how and what and when you would like information shared in the future. Today we are, oh, and one last thing. Before we go into our presentation, Dr. Loeys is going to share some slides and a brief introduction, and then both doctors will be answering your questions. Please do drop them in the Q&A box. We will be looking around in the chat if you happen to drop them in there, but we will for sure see them if they're in the Q&A. We will get to as many of them as possible. However, if we are not able to get to your question today, you're always welcome and encouraged to share it at marfan.org/E3ask. And we will get you answers just as quickly as possible. And with that, I am going to hand this over to both Dr. Loeys and Dr. Dietz. If you would like to do a quick introduction, and then we can get started in your presentation.
Hello, good afternoon for the American side, good evening for the European side. It's my pleasure to welcome you on behalf of Hal. We will give a very brief introduction, mostly discussing a little bit the genes and the nomenclature, And then afterwards, we can get to the questions that might be more clinically oriented. I will share my screen. Okay, does everybody see the screen?
Looks good.
Okay, thank you. So in 2005, we published for the first time 10 patients that presented at that time a new syndrome that was related to Marfan syndrome, but did have some very specific characteristics. They are illustrated here on this slide. The three most typical ones, which are called the triad for this new syndrome, were the widely spaced eyes, as you can see here on the image, which is also in this morphology terms called hypertelorism. We also observed that those patients had more often a cleft palate or a bifid uvula, and you can consider a bifid uvula as a minimal expression of a cleft palate. And then most importantly, which was different from Marfan syndrome, is that we noticed that those patients tended to have aneurysms that were larger at younger ages, were more widespread throughout the arterial tree. As in Marfan syndrome, it's typically affecting the aortic root, so right where the aorta comes out of the heart. But in this new condition, they occurred at many other places, including the side branches coming off the aorta. And there was also something that we call arterial tortuosity. So there is a more increased twisting and winding of the arterial side branches and also of the aorta. We described it as an autosomal dominant condition. That means that it can affect both males and females. And dominant means that there is a 50% chance of transmitting it to the next generation, irrespective of the gender. We also noticed quite quickly that there is a wide range in clinical expression, meaning that not every patient did have this typical triad, that it could be more subtle in the facial findings. And also there is a wide range in the uvula findings, which might be sometimes just a broad uvula with only a minor raphe in the middle. In some cases, it's the consequence of a de novo mutation, which means that both parents are unaffected and that a mutation happened in one of the genes causing this new disease, which is now called Loeys-Dietz syndrome. Like Marfan syndrome, we noticed that there could be skeletal findings, including scoliosis, and which is a curvature of the spine, chest wall deformities with either the chest going in or outward, called pectus excavatum or carinatum. There could be long fingers, also called arachnodactyly, but there is also features that are quite unique, in addition to the triads that I already described with the hypertelorism, so the widely spaced eyes, the cleft palate bifid uvula, and the aneurysm development throughout the arterial tree with the tortuosity. We also noticed that there is quite often craniosynostosis, so a premature fusion of the skull bones. Many patients also present problems at the cervical spine with neck instability. Club feet is more common than in Marfan syndrome. And we also noticed some other congenital heart anomalies, such as the bicuspid aortic valve. A normal aortic valve is consisting out of 3 leaflets. Many patients with Loeys-Dietz syndrome have only 2. There could be connections between the systemic circulation and the lung circulation called patent ductus arteriosus, or connections between some of the parts in the heart called atrial septal defects. As you can see at the images, there is also not only joint hypermobility, but also contractures, specifically of the fingers. So soon after we described it clinically, we identified the TGF-beta receptors as the causal genes, which we published in 2005. As you can see here on the figure, the TGF-beta receptor is a receptor at the cell membrane that allows TGF-beta to signal into the cell. Although initially we called LDS type 1 the more severe type with the more outward features, and type 2 as the less severe outward features, very soon we recognized that this is a more widespread disease caused by also mutations in other genes. And from that time on, we started calling the different subtypes of LDS by their gene names, with TGF-beta receptor 1 being LDS1, TGF-beta receptor 2, LDS2. Soon after, colleagues from the Netherlands described mutations in SMAD3, which is the first downstream effector after the cytokine TGF-beta binds to its receptor on the cell membrane, as another variant of this condition. They noticed that in this type 3, patients also had more osteoarthritis as a finding, but we do know since that there is also families without this osteoarthritis that share much more characteristics in common with LDS that make them part of the same group of diseases. As you can see here in this example, we noticed also typical findings such as the craniosynostosis, the hypertelorism, and the bifid uvula as part of this spectrum. Similarly, we identified, along with the French group, mutations in TGF-beta 2, which is the ligand, or one of the ligands that binds to the receptor, again showing the whole broad spectrum, ranging from the outward features with the hypertelorism, cleft palate, but also the severe cardiovascular phenotype in some families. For example, in this patient, he had a mitral valve surgery at age 20, had an early onset aortic need for aortic root replacement, and also had dissections of the side branches. So completely resembling what we first described in the patients that have mutations in TGF-beta receptor 1 and 2. And then the last one, which is probably one of the mildest forms that we've seen so far in general, but again, there is a wide range even within a single gene, is TGF-beta 3, which is another isoform of the ligand that can bind to the receptor and leads to a phenotype that's very reminiscent of the initial description. So that's why we all group them together now under Loeys-Dietz syndrome. A condition that resembles Marfan syndrome and Loeys-Dietz syndrome is called Sprintzen-Goldberg syndrome. In those patients, there is also almost always craniosynostosis as a finding. And moreover, most of the patients also present with developmental delay. So they will have problems in their motor development and sometimes also learning difficulties. Because of the resemblance, we did add it here to the figure, and also because it is molecularly linked to LDS, in the fact that the gene causing Sprintzen-Goldberg syndrome is called SCI, and SCI is an inhibitor of this pathway that was involved by the mutations in the ligand, the receptor, and the effectors of the signaling called the SMAD proteins. So overall, we do have now at least 5 established genes, receptor 1, receptor 2, SMAD3, TGF-beta 2, and TGF-beta 3. We also observed mutations in another family member called SMAD2. And again, those patients do present with a phenotype that is very reminiscent of the initial description. So I think it deserves to be called type 6. And we are working on another gene that's involved in this pathway, again, with patients that have mutations in those genes. So we're definitely not yet at the end of discovering genes that cause this phenotype. Hal made this very nice comparative table. We will not go into all the details. I will just point at the main differences. So in red, we've indicated findings that you almost never see in this condition. In green, you see findings that are very commonly seen in this condition. And then the yellow is kind of in between. It is present to some extent, but not very typical. So there you can see that ectopia lentis is a finding that's uniquely present in Marfan syndrome that we do not observe in any of the subtypes of LDS, nor do we see it in Sprintzen-Goldberg syndrome. When we move more to the second half of the table, there you can see that craniosynostosis, as I mentioned, is something that is common in most of the LDS subtypes, also typical in Sprintzen-Goldberg syndrome, but absent in Marfan syndrome. And the same can be said with regards to the cervical spine instability, which has been observed in most of the types of LDS, but not in Marfan syndrome. When a child presents with developmental delay, the first diagnosis is probably Sprintzen-Goldberg to think about. And then at the bottom, you can see many more of the characteristics that we talked about that are definitely more typical of LDS and absent from Sprintzen-Goldberg and Marfan syndrome. And we can talk more about these during the Q&A. What about the distribution of the occurrence of those genes? The most common one is still TGF-beta receptor 2, which is about half to 60% of all the patients with Loeys-Dietz syndrome. Probably 1 out of 5 patients does present with a TGF-beta receptor 1 mutation. And then the other more recently discovered genes probably explain somewhere between 5 and 10%. Of course, these are more recent in discovery, so those numbers might change a little bit. And for example, SMAD2 is very recently added, but we only are aware of a couple of families with this gene as a cause of LDS, and that might increase also in the future. I've given here a little bit of an idea on the degree of severity as we see it now. The TGF-beta receptor 1 and 2, along with SMAD3, tend to be more at the severe end of the spectrum, which is evidenced by the fact that there is more systemic features. So you will see more cleft palate, more club feet, more craniosynostosis, and also more examples of young age of onset. Whereas if you move more to the right of this distribution, specifically with TGF-beta 3, you can see that there is much more examples of a very mild expression, or even something that we call non-penetrance, which means that an individual carries a pathogenic variant mutation in TGF-beta 3, does not show evidence of, for example, aortic aneurysm, at least not at a young age. They might develop that at a later age. So that's where the nomenclature and the different subtypes can be identified, and how we would range the disease severity. But I have to stress that even within a gene, there is a significant variability. You can also have families with mutations in, for example, TGF-beta receptor 1 and 2 that do present much milder disease with less systemic features. What exactly is determining this severity is a matter of research. We believe that probably variation in some of the other genes, we have 21,000 in total, might modify the primary outcome of this mutation. So this is an introduction, and we will now answer the questions.
That was a very good introduction. And I know at least one of the questions in here asks about main characteristics of each type. So I just wanted to note that I will put these slides into the session so that if you want to take a closer look at that chart that detailed that out, it will be available here shortly within where you're viewing the presentation. So the first question, and I'll let you two decide who wants to start here. Perhaps Dr. Dietz, it's your turn to chime in first. This says, the Loeys-Dietz Syndrome Foundation website has a diagnosis primer from 2014 on the website that we give medical providers who are unfamiliar with LDS. Are there any additional or newer resources we can or should provide, especially for patients who only have 1 or 2 doctors on their care team that have had an LDS patient before? So I guess the question is, any changes in the last 6-ish years?
So the primer that is available is really quite comprehensive. It anticipated that there would be new genes and new developments, but it's still very accurate. You know, I don't think that there's any information presented in that primer that we would back away from or currently consider controversial. The Loeys-Dietz Syndrome Foundation continues to make educational materials, and then there are also a number of efforts to capture information from lots of people with Loeys-Dietz syndrome throughout the world, so we can do an even better job of providing diagnosis-specific recommendations. You know, one thing that, as Bart mentioned, we have learned is that there is a wide range of variability, both within a diagnosis caused by a specific gene and certainly between genes. And, you know, I think the important message to get across is that you and your doctors should work together to make sure that they're giving you the best information for you in particular, not the best information for the average patient with Loeys-Dietz syndrome, or not even the best recommendation for the average person with your type of Loeys-Dietz syndrome. But rather, there should be an effort to try to gather information from every source possible. What about people with this specific DNA change? Have they been described before? What about your family members that had Loeys-Dietz syndrome or have Loeys-Dietz syndrome? How did they behave? You know, that might give a clue about the modifiers that Bart was talking about, and whether there might be special protection. So, you know, I think the biggest challenge and moving forward from the primer that was published a few years ago is to try to learn how to personalize this information and how to make informed, individualized recommendations. And I think that's a topic we'll likely talk further about in this session.
Thank you. Next question. Wondering if there's any research on having LDS or as well Marfan syndrome and having menopause. I'm curious how losing estrogen affects women's bodies when having a connective tissue disorder.
All right, I'll jump in on that one and then let Bart take the next one. So it's an excellent question. It's becoming a more important question as people with these connective tissue diagnoses are now routinely living into old age and have to learn about how age-related events such as menopause might interact with their underlying connective tissue condition. We do know that hormones, including male or female sex hormones, can influence the severity of the disease. For example, we have learned in Marfan syndrome mice that the female hormone oxytocin that is released at the end of pregnancy and also during breastfeeding can aggravate the aneurysm condition. There is information for a variety of vascular connective tissue disorders that male sex hormones called androgens can make things worse, and that blocking androgens might ultimately prove to be a good treatment strategy. For other connective tissue or aneurysm disorders, and again, particularly in mouse models, there's some evidence that estrogen can be protective. That's something that has not, to my knowledge, been explored in Marfan syndrome, but I think it should be highlighted as an area for further research. It is an important question.
Maybe just to add on to that, it might be also important for the skeletal findings. For example, we do know that women with connective tissue disease that have joint hypermobility, that pregnancy also influences that, and that might indicate that changed hormones to alter joint hypermobility. So not only for the vasculature, but also for the skeletal system, there might be some influence.
I would say bone density as well. You know,
exactly. Yes. Yeah.
Certainly, hormones influence the ability of your bones to incorporate calcium and to remain strong in old age.
Very good. Thank you for all that. Next question we'll toss to you, Dr. Loeys. How often should you get a neck flexion X-ray to check for instability?
Bart, I think you're muted.
Sorry. So again, I think a very important question because it's not a characteristic that, oh no, my phone is ringing. I need to give it to my wife. 1 second.
Dr. Dietz, you want to try and answer
Maybe
that
I'll
one?
jump in on that. So we do know that either malformation or instability of the spine in the neck can be seen in multiple forms of Loeys-Dietz syndrome. And sometimes that instability can be serious. It could put someone at risk, for example, of spinal cord damage, even with a minor accident. So we feel very strongly that people with Loeys-Dietz syndrome should have neck imaging at the time that the diagnosis is first being considered, often in early childhood, but sometimes in later adult life. We do know that in people that initially show a normally formed and stable neck, that instability can develop over time. And that may be particularly true in children with Loeys-Dietz syndrome. So with children, we typically recommend repeat neck imaging every few years, perhaps every 2 to 3 years. And that can be done just with a regular X-ray taken when the head is bent forward and when the head is bent back. For adults that have previously shown a normally formed and stable neck, I think it should be looked at intermittently, but also less frequently. It's much less likely to evolve over time. So perhaps every 5 years or so.
Okay, we're going to try you again, Dr. Loeys.
No, sorry.
No, you're fine. It's totally fine. Could you talk about cranial cervical instability in LDS? Any new HCTD types that have been discovered? What is the usual cause of cerebellar tonsil ectopia or Chiari in LDS? My goodness.
Yeah.
That's a mouthful.
It's like the, 3 different questions, I think. So the first one, I think, was largely addressed by Hal. I don't think we have anything to add to what was already been said about cervical instability. So as I pointed at, we are currently investigating a new subtype, which is somewhat unusual because it does present with a different mode of inheritance. So most of the ones that are known by now, or all of the ones that are known by now, are autosomal dominant, but this new one is an autosomal recessive, which means that both parents are carrying a variant, and that they need to transmit both that variant to the child in order for the child to develop the disease. We are investigating what the specific role of the gene is, but again, there seems to be a connection to the TGF-beta signaling pathway. So we'll let you know more once we know more. We did develop a mouse model, and the mouse model also develops the aneurysms that we see in the children, so we can use that model to learn more exactly about the function of the gene. And then the third part about the Chiari malformation. So I think that could also be related to changes in the way the cervical spine is made, and the bottom of the skull. So I don't know whether that answers completely the question, or I'm not sure I understand the full question.
I think the question was trying to ask what causes Chiari malformation in heritable connective tissue disorders. And you know, I don't think that we know a precise answer to that. As Bart is suggesting, it likely relates to how the lower portion of the skull and the cervical spine form during development. There is evidence that it can progress over time with the lower portion of the brain sinking more deeply into the spinal canal, but the exact determinants of why someone has a Chiari malformation and someone else with the same underlying diagnosis does not, you know, I don't think we have a good answer to that.
Okay, there are several questions, as is not surprising, about different types of imaging, a lot of imaging questions. So I'm just gonna see if I can lump these together and we can do a series of imaging questions. The first one is about, should you be getting MRIs or CT scans below the pelvis to check for aneurysms?
Do you want me to do that, Bart, or do you?
No, I thought she was going to add more questions to it, or not.
I'll
do them one by one.
All right, so if I understand the question correctly, the question is, should there be routine use of imaging below the pelvis, for example, in the lower portion of the legs? Is that the gist of the question, Angela? Yeah. So we've learned where the hot spots are throughout the arterial tree for aneurysms to form or for tears to occur. Certainly that includes the chest and abdomen, which are always included in imaging. We learned over time that the neck and to a slightly lesser extent the head is also an area where vascular issues can develop and can become serious. So on that basis, the head and the neck are routinely included during imaging. The pelvis is an area where the aorta is splitting into the two large blood vessels that go down to the legs. And we have learned that that branch area is also an area of predisposition. So we routinely go image into the pelvis. Involvement below that is first relatively rare. It's not that it can't happen. We have seen people with aneurysms in blood vessels, for example, behind the knees. But not only is that less common, but it also is less likely to develop a serious problem if a blood vessel tears or bursts. There's a lot of, there's not much space for bleeding to occur. So it would be unlikely that someone would have a really serious outcome like death due to hemorrhage if a blood vessel did burst in the legs. If someone does have a tear in the lower portion of the aorta or the branch vessels that are going out to the legs, then we would start imaging lower down, including into the legs. If somebody has symptoms such as pain or difficulty with walking or something that we can't explain on some other basis, then we would also begin routinely looking below the pelvis. But in general, because of the rarity of the problem and because it does not typically lead to a catastrophic type of event, we don't routinely perform imaging below the pelvis.
Okay, next question, kind of on that. Sorry, I was scanning down to see if there were any others I wanted to catch here. Was about children and how often they should be getting an MRI imaging done. 2 kids with SMAD3, is every 2 years acceptable? As I have read, how quickly things can change for them, and their birth father died in his early 30s. This is imaging about, looks like young children.
Yes. So I think I want to echo some of the things that Hal said earlier. We do try to individualize management for each family. There is some general guidelines, but as Hal already indicated, it is important to look at the nature of the mutation, the nature of the gene, the family history that is there, and that should also determine the frequency of the imaging. In general, we do perform regular echocardiography because still as in Marfan syndrome, in LDS, the most commonly affected site is the aorta, where the blood vessel comes out of the heart, so the root and the ascending aorta. But we do add additional imaging, as was discussed also by Hal. At least a baseline imaging should be performed, which would be a CTA or an MRA, including the brain and the pelvis. And then we make decisions based on the initial results. If something is observed on that baseline imaging, it might be necessary to repeat that within a year. If everything looks completely fine, no aneurysms, no severe tortuosity, then we can probably spread out the interval. I think initially we recommended doing it in everybody every year, but we are learning, and in those individuals that have milder phenotype, I think it's fine to extend that interval to every 2 years. Maybe later on when they get older and you have several normal images, it could be 3 years even. Yeah, I think that answers the question.
Okay, I think that covers most of the imaging questions that I've seen here. I'm going to move now to.
Can I?
Go ahead.
I'm going to ask a question about imaging because I think it should be discussed. So, Bart, should people do MRAs or CTAs? What's the difference?
Okay.
Why pick one over the other?
Yeah, well, so the difference, I'll explain that first, is the MRA is based on magnetic resonance, so does not involve X-rays, whereas the CTA is based on X-rays. And so there is some concerns that if you do too often CTAs, that might be not so good for the tissues. And although we do know that over recent years, I think the load of X-rays has improved. So that's one consideration that's been taken into account, specifically in children. But I think the other important aspect is also the expertise that's there at your local center. I think if there is more experience in interpreting CTAs than with MRAs, I think we should weigh the advantage and the disadvantage, and then maybe the experience and the expertise in the center is more important than the X-ray burden that we do get. Anything else that you thought that we should mention?
Yeah, so I think that the radiation exposure issue is one that we now think a lot about. You know, it's clear that a lot of radiation exposure can increase the risk for things like cancer. It's also clear that our body has memory for how much radiation it's seen throughout a lifetime. So we have to be aware of how much exposure someone's getting. And if they have a condition like Loeys-Dietz syndrome, we can anticipate that they're going to need imaging throughout a long lifetime. CT scans and MRI scans both give nice pictures. The CT scan has the benefit that it's really fast. MRA scans can, to do large segments of the body, can take an hour or more, and that can be particularly challenging for a young child. So occasionally what we'll decide to do in a young child is to initially do CT scans because they're super fast. They take literally seconds to image the whole body, but then plan on transitioning to MRA scans once the child can cooperate and would not, for example, need anesthesia to have a prolonged MRA scan. The other issue is an issue of resolution. So while I said both are good, CTA scans are somewhat better to look very carefully at small blood vessels. And often in the head, after an MRA scan, the radiologist will have a question. They'll say, I'm not really sure whether what I'm seeing might be a tiny little bulge in a blood vessel or whether it's just a part of the normal anatomy. So sometimes when that kind of question comes up after an MRA scan, it will be recommended to do a CT scan of the same area to try to get a more clear view. That's not so important with bigger blood vessels and has in particular been an issue in small blood vessels in the head and neck area.
So another issue that we encounter, I don't know whether it's country specific, is that there's also different rules for reimbursement of MRAs and CT scans. And somehow it seems more difficult for the radiologist to combine an MRA from head to pelvis in one session because they're not allowed to do that many MRA on one day, whereas they are allowed to do it on a CT scan. So sometimes that also comes into play. I don't know whether that's happening in other countries too, but that for us sometimes has been also a reason to do a CTA rather than an MRA.
Yeah, I mean, I have heard about that issue before. I don't think it's an absolute issue. For example, We traditionally do MRA all the way from the head through the pelvis in a single day in a single sitting. So
Yeah.
it can be a problem at some institutions, but it's a resolvable problem.
Yeah, well, it's also in Belgium, it's a matter of reimbursement. The patient cannot get reimbursed if he gets 2 scans on the same day.
So kind of jumping off that, the next question, and I think this could probably be taken a little more broadly even. My 22-year-old son was diagnosed with LDS 4 1 year ago. The only thing he's done is the head to pelvis MRAs. He's in denial since he doesn't exhibit any symptoms, pains or problems. I'm trying to nudge him to speak to a medical team to monitor his condition. What specialist should he see first? And I think perhaps the broader question here is, you know, sort of a young adult monitoring health, defeating the infallibility curse of the young adult and a condition like this.
Yeah. So you're not alone in facing the problem. Problematic people tend to be relatively young, and as Angela was mentioning, have this view of invincibility. I would honestly say that men are typically more problematic than women. That might be a generalizable rule. But I think it's important to get the message across that we've learned a lot of lessons about how to care for people with Loeys-Dietz syndrome, and we think what we're doing makes a difference. In fact, in many respects, we're sure that what we're doing makes a difference, including, for example, referring for surgery at smaller aortic dimensions. A message that I'd want to get across to a person who's sort of in denial is that many people with a wide variety of vascular connective tissue disorders feel just fine. They feel normal. They feel perfect until the moment a blood vessel ruptures. That could, for example, lead to their death. So, while feeling good is great, it should not be taken as, complete reassurance that there is no problem brewing. I would certainly recommend that this young man identify someone that is knowledgeable about the diagnosis. That might be a cardiologist, it might be a geneticist. In some circumstances, there are general practitioners who have learned quite a bit about the condition. In any event, he should find someone that's either knowledgeable or curious and willing to learn, that's going to help manage his care. I do think that seeing a cardiologist or someone who's going to review cardiovascular imaging studies on a regular basis is important. Again, someone who's familiar with the use of medications, the interpretation of genetic testing would also be very helpful. Some people don't need to see an orthopedist frequently, and others do because they have significant bone problems. Unlike Marfan syndrome, eye problems in Loeys-Dietz syndrome are relatively uncommon. So, an ophthalmologist, while everyone should see one intermittently, is not necessarily someone that should be seen on a regular basis or a frequent basis in someone with Loeys-Dietz syndrome. I really think it's a combination of a primary medical doctor, a cardiologist, and or a geneticist that's going to be able to provide the most value.
So another side of that same coin, perhaps, is asked how to, and maybe we could word this multiple different ways. How do we teach doctors that don't want to learn? $1 million question, right? So I suppose, again, to broaden that out a little bit is, what are the key points that need to be emphasized, or is it just a matter of don't and find someone who is willing to learn, or find someone who already knows? I know for some folks, and I can kind of speak from my own perspective here, I live in a very rural part of the United States. My options are few if I needed to find such a specialist. So we do encounter people who feel like they don't have any other options but to educate. So, you know, given the range of people's constraints, just I think this is a really interesting question coming from the both of you.
You want me to, Bart, you're muted if you're talking.
Yeah, sorry. So I think something that I always try to convince the patients or that I help them with is to be as accessible as possible as specialists. So usually we try to work into a scheme where maybe with large intervals, they come to an expertise center, and we at least try to identify somebody locally that can do the more regular follow-up, and then try to make a connection between those two by being available to also look at intermittent imaging just by email in the imaging and the results, and giving advice over email. And I think that has worked really well. So I think then the local physician has still the feeling that he's in charge, but has some support of an expert center that's more distantly located. That's usually how we try to tackle it, because I can understand that it's very hard for some people to always travel long distance to a specialist center. But once that you are known there, it should be feasible also with modern techniques to have video conferences and exchange of imaging to give advice even over longer distance.
I mean, one thing I would add is, you know, just because someone doesn't know a lot about Loeys-Dietz syndrome does not mean that they're not a great doctor. You know, we're good at what we do. We're good at what we see. You know, I am still learning about Loeys-Dietz syndrome, and you know, I hope that I never get the mindset that there's nothing more to learn. If your doctor doesn't know a lot about Loeys-Dietz syndrome, but you know, is curious, is asking you questions, is asking where they can learn more information, is writing down the address of the Marfan Foundation and Loeys-Dietz Syndrome Foundation as you're talking about it, is asking for records from other hospitals, and, you know, asking who have you seen and tell me about these people and their experience. You know, that's a great sign. And as Bart mentioned, it's often possible to coordinate care from a distance with intermittent visits with a specialist and more regular visits with your local doctor. That works best when there's a partnership, you know, when the local doctor and the specialist respect each other, trust each other, are interested in learning from each other. And, you know, I think that that's often quite possible. I would say in the majority of the people that I see at a distance, I know their local doctors by name. I've had many phone conversations, email conversations, and now Zoom chats with them. So that can be an ideal situation when that type of partnership can be struck.
That's a great approach. I'm sure there are a lot who will appreciate that guidance. Switching gears here a little bit, how common is dysautonomia in LDS, specifically temperature regulation and heat intolerance?
So that's not something that I have associated with LDS. That does not mean that I haven't on occasion heard about people with LDS who say that they're always cold or always hot or have difficulty sweating. My first suspicion when I would hear about that in someone with LDS would be to consider other causes for the problem, because that simply has not emerged as a recurrent or in any way frequent finding in Loeys-Dietz syndrome. It should be considered that that type of issue might be aggravated by a vascular problem, especially, for example, a dissection that's limiting blood flow to a part of the body, that perhaps some of the medications that are used for LDS and other vascular connective tissue disorders might in some way contribute to or aggravate the problem. But if somebody has true, severe, long-standing, unexplained dysautonomia, my strong suspicion would be that another cause needs to be found.
Okay.
So specifically in the group of disorders called Ehlers-Danlos syndrome, I think you see it much more. It's almost a typical presentation. So, and of course there is some findings that might be reminiscent of what you see in LDS, like the joint problems, joint hypermobility can happen both in Loeys-Dietz and Ehlers-Danlos syndrome. So there might be some overlap in the findings, but I agree with Hal that it's not a typical symptom for LDS, rather for Ehlers-Danlos syndrome.
So I think an important distinction to make, though, is I'm describing the term dysautonomia by a very rigorous definition, and also responding to the question where temperature control was the major problem. Many people with many connective tissue disorders, including Loeys-Dietz syndrome, feel lightheaded when they stand up quickly. And that can also fall under the broad category of dysautonomia, although I don't believe that that's a really rigorous use of the term. But if that's what the person asking this question is talking about, then I would change my answer and say that's quite common in vascular connective tissue disorders, likely related to the stretchiness of blood vessels, and with issues mobilizing fluids in and out of the blood vessels, and mobilizing fluids to get back to the heart. In that circumstance, things like drinking lots of fluid, using compression stockings, either adding a little more salt to the diet or using a medication that increases the kidney's retention of salt, they can make a difference. But if this individual has been diagnosed with dysautonomia by a specialist with prominent temperature control issues, I would stand by the original answer that there's likely a different cause.
Okay, question about losartan. If you can't tolerate a high dose, and this person says, in my case, due to low blood pressure, will losartan still make a difference?
Yeah, so we're still in a very early and active stage of learning about use of medications for vascular connective tissue disorders, including Loeys-Dietz syndrome. What we can say with absolute confidence is that angiotensin receptor blockers like losartan or irbesartan or a few other medications, all in the same family, they really are magical in their ability to protect mouse models of Loeys-Dietz syndrome. I mean, and I don't think that there's any controversy about that. That experience has been repeated by many different research groups all over the world. The important point is that in that context, we're not just using these medications to keep blood pressure low. We're using these medications to alter the biochemical activity of cells within the blood vessels. And we know in those mouse model experiments that that is the critical determinant. So you have to use relatively high doses of these medications to have those desirable biochemical effects. And that's why we have high incentive to try to get to as high a dose as possible, up to a predetermined limit, you know, how high is allowed. I think that, you know, in general experience, medications like losartan and irbesartan do a good job at lowering a high blood pressure, but don't tend to have much of an effect on a normal or even low-ish blood pressure. So it's been very uncommon for us to not be able to get to the high level target dose. Sometimes it requires a very slow increase in the dose over time. Sometimes it requires splitting the dose, so giving half in the morning and half at night. It's often strongly recommended that people drink plenty of fluids as they're just starting to take a medication and as the dose is increasing. You know, how much is enough? That might vary from person to person. So, you know, I still think that there should be incentive for someone to take one of these medications at the highest dose that's tolerated. But, you know, with losartan, we would typically want to get to a dose of 100 milligrams per day in an adult. And at least 2 milligrams per kilo per day in a child. With irbesartan, we try as hard as we can to get to a dose of 300 milligrams per day in an adult, and around 8 to 10 milligrams per kilo per day in a child. So this is something that should be discussed with this patient's doctors. You know, if this person could tolerate a high dose of beta blocker, but can't tolerate a higher dose of angiotensin receptor blocker, then it may make sense to use a beta blocker in this individual. You know, it's much better to reach what is thought to be an effective dose of at least one medication rather than giving just a touch of 2 or 3 medications. So every effort should be made to reach what's considered meaningful dosing for at least one of these medications, and in general, either an angiotensin receptor blocker or a beta blocker.
Yeah.
Oh, go ahead.
I agree. I just want to add that the echocardiographic follow-up also tells you a little bit on how much a person needs. Like if you don't get to the high dose, but your aortic Z-scores remain the same, that might indicate that the dose that you get is sufficient.
Okay. Questions, a few of them here about life expectancy. One asking, has the life expectancy statistic changed in the last decade? And also about lifespan expectancies for types 1 and 2, specifically more severe end of type 1 especially.
So, you know, when Bart and I first described Loeys-Dietz syndrome types 1 and 2, the people that made themselves known to us first were the people at the most severe end of the spectrum. So at that time, we provided an accurate assessment of what we saw, which suggested that there was a high risk of vascular events early in life, and that life expectancy was greatly reduced. So as Bart mentioned, since that time, we've learned that there's a wide spectrum even within a given diagnosis. So, I've had the pleasure of caring for quite a few Loeys-Dietz syndrome type 1 and 2 patients who are in their 60s, 70s, and even 80s. I also, as Bart mentioned, we've seen other flavors of Loeys-Dietz syndrome caused by other genes, where overall, on average, the condition tends to be somewhat milder. So I really don't know that it's important to dwell on life expectancy numbers when you're talking to an individual person or family. Again, what should be done is using all information possible to provide them with the most accurate information for their particular circumstance. With Loeys-Dietz syndrome, for many of the genes, we are now collecting a lot of information on specific mutations. So, we would not only say Loeys-Dietz syndrome, we'd not only say Loeys-Dietz syndrome type 2, but we would say Loeys-Dietz syndrome type 2 caused by a mutation at this position. Then we're starting to perhaps give really relevant information for that person. That's the challenge, and that's what a lot of ongoing precision medicine efforts are trying to tackle, to get really granular information for a specific individual.
I think in general, making the diagnosis in itself should make a difference on the life expectancy, because you can try to prevent things from happening, which when we first published it, we only had historical information to look back on. And as Hal said, that's the more severe presentations come to medical attention first.
That's a good point. It can dramatically change if there's an accurate diagnosis, right? So a couple more themes here. One, a couple of questions around puberty. One is about, is there anything to suspect that a late onset of puberty would be caused or be an effect of LDS? And then more questions about, how does puberty affect teens with LDS? Does it significantly lower muscle tone, decrease joint stability, aortic changes, other impacts?
Does LDS influence the timing of puberty? I think in general, the answer is no, that we each are programmed to start puberty at a certain time. Often, if you talk to parents of a child, their experience as to when they went through puberty will predict when their child will go through puberty. Young women tend to go through puberty at an earlier age than young men as a broad rule. I think the exception about might LDS in some way influence puberty would include children that have severe gastrointestinal issues and have a really severe problem putting on weight. It's known that you need a certain body mass and particularly fat mass to have the right mix of hormones that, will initiate puberty. So it is possible to have delayed puberty on the basis of a really, really low body mass. And again, that's typically only seen in the subset of children that have severe gastrointestinal issues. Now, can puberty influence features, severity, manifestations of Loeys-Dietz syndrome? The answer to that is yes. We know, for example, that many of the skeletal features of connective tissue disorders like Loeys-Dietz syndrome and Marfan syndrome are driven by growth. So as you go through the rapid growth spurt that's associated with puberty, that can make chest wall deformity worse. That can cause an acceleration of curvature of the spine, for example. Also around the time of puberty, there's the release of hormones that we've already talked about, can, at least in some circumstances, influence blood vessels and how they perform. Also, around the time of puberty, blood pressure often goes up. So it's possible that a higher blood pressure might lead to some acceleration of cardiovascular issues. And it's also known around the puberty that around the time of puberty that some behaviors change. Young boys, for example, might start getting really interested in heavy weightlifting, which is something that might also influence how blood vessels perform. So it is a time when we, pay close attention. Not that we're not paying close attention before, but I certainly wouldn't become more relaxed around the time of puberty. I would certainly be maintaining all the frequent surveillance that's done throughout childhood.
Okay, so I am aware of the time here. We've gone over by about 10 minutes, but I'm certain that has been sort of the standard for the two of you during this whole summit. I'm looking through the questions and I'm seeing a few other themes here, and I just thought I would grab one more and remind everyone, if your question is not answered today, please do submit it to marfan.org/E3ask, and we will be happy to get answers and get you the information you're looking for. We were just not able to get to quite all of them in one session, but want to try and get some of these broad themes covered. A lot of questions here on chronic pain. And I know we see that a lot in trying to treat chronic pain. I don't want to get into anybody's major specifics here, but just, I guess, thoughts on ways to manage chronic pain in LDS at different ages, and I think particularly as people age and start getting into arthritis and things like that as well.
You want to take that one, Bart?
Yeah, well, I try to, especially in the young children, to motivate them to start doing the right exercises and the right type of exercises at a young age, in order to reinforce the muscles that might compensate for some of the laxity that's present in the joints. And by this laxity, they might have increased frequency of joint damage later on in life. So one of the things that we almost always recommend start doing at young age is swimming, because during swimming you do reinforce your muscles and you don't put too much pressure on your joints. So that's trying to work in a preventive way. Similarly, when they do running. We try to stimulate to do that running on a rather soft surface rather than on a hard court. So I think if the diagnosis is made early on, trying to try to do the right exercises in the right circumstances might prevent a lot of the joint issues and pain issues later on in life. I think later on in life it can be challenging, and usually it is a combination of doing additional physical therapy, pain medication, additional joint support, things like how do you call them, splints, that help to manage daily life activities.
Yeah, I think it's important for people to have their experiences with pain validated by the people who are caring for them. You know, in connective tissue disorders in general, pain can be a prominent issue. Sometimes, in fact, often, there's no obvious overt reason for the pain, but you have to make sure that you're working with a doctor that is not dismissive of your experience of pain. Every effort should be made to get to the bottom of why pain is present. You know, there are lots of reasons for back pain, including disc problems, including other bone problems, including dural ectasia, which can cause impingement on nerves in the spine. So, you know, everything should be done to try to understand why someone has pain and to see if there's something that can be done about it. With regard to interventions, my general recommendation is not to rush to surgery, to try all the kinds of interventions that Bart was mentioning, to see if something can be, some intervention can be found that provides relief, but sometimes surgery is needed. Make sure you're seeing someone who's experienced with that problem and with that surgery in connective tissue disorders. That can be challenging because sometimes the surgical approach is different or the expectations for recovery are different. With pain medications, try to use the mildest and least frequent medications that work for you. Again, don't jump directly to opioids, for example, that have their own obvious sets of problems. We do now often turn to colleagues that are pain specialists to help come up with the best program that can include sometimes medications plus physical therapy plus biofeedback plus a number of other potential alternative modalities that can be helpful. So my bottom line is, don't just decide that you need to live with pain. Don't settle for doctors that are dismissive of your pain, and be open-minded about the types of things that might help you get to a better place.
That's a really great response, and I so appreciate your commenting on don't settle for doctors who dismiss pain. I think that is a common frustration that we hear in the community, and both Marfan, Loeys-Dietz, I mean, they're all experiencing some of that, and I'm sure it's extremely reaffirming to hear that, especially from you both. So thank you for that. I am going to pull us off here, take the off ramp while we have a moment. There are still a few questions in here, and they are also valuable. We just unfortunately cannot we don't have the time to get to them all today, but if your question was not answered, please do submit it to marfan.org/E3ask, and our team will make sure you get some answer to that question. I also wanted to note, as you were speaking about, Dr. Loeys, you were speaking about physical activities that help support those areas where there is some chronic pain. There was a concurrent session Dr. Braverman was doing today about physical activities and can I do this or that, and I dropped the link into our chat. It is not, the recording is not yet up because it just finished, but it will be there very soon. So if that's something of interest, you might want to follow that link. Give us a day or two and that'll be up. So here we are. We are officially the last people standing in E3 because the other sessions have wrapped up. Want to thank you both for your time, your attention, and expertise, and in sharing everything you brought both today and in the past that has led us up to this point. I did notice a couple of comments in the chat thanking you both for the work you do and how life-saving it has been to some of the folks who are sharing there and to their family members. I have a few things I want to mention just to wrap up for everyone. Where'd my screen go? If you have not yet filled out your feedback on this session, please do so by hitting the rate link as you leave. Whether you view this live or later on, we very much appreciate your feedback. And also the summit survey is up. This is beyond the individual session surveys. This is for the whole experience, whether you've attended one session or 70. We are really, really interested in your thoughts and your feedback on this experience as we begin to assess and plan for what the future of programming like this looks like from the Marfan Foundation. So that is located at marfan.org/E3survey. The exhibitor hall will remain up, the community will remain up. Please continue to engage with those in whatever way feels useful to you. We will continue to use and monitor the hashtag E3Summit20. And if this has been a wonderful experience for you, like it has been for us, we invite you to support us in making more things like this happen again in the future by visiting marfan.org/donate. Finally, we do have Aortic Disease Awareness Week is coming up later on in September, begins September 19th, and we are right now taking submissions from you and all people across our community, inviting you to raise your hands to raise awareness for the risk factors for aortic disease. So if you are affected by Loeys-Dietz, you could submit your hand, holding up your hand, raising awareness for Loeys-Dietz as a risk factor for aortic disease. You can submit those through marfan.org. There's a link right on our homepage for where you can drop those in. And with that, I thank you both. I thank both of you, all of our attendees, and our sponsors for making this such a wonderful, wonderful 3 weeks. I know you two have been with us a lot through this process. We are so grateful. You are such rock stars in our community, and we're incredibly honored to have your care and patience with everybody in our organization and with our community. So with that.
So Angela, I would like to take the opportunity to thank and congratulate you and Susan and everybody at all the foundations for a really remarkable series of educational opportunities and an ongoing resource for people. As you mentioned, people will be able to come back to these sessions. So thank you for all that you do and all that you're doing.
Yeah, I think
it's an honor to do this work. It really is.
I think we should add to that that the real rock stars are the patients that are asking the excellent questions.
Yep.
Yeah, for sure. All right. Well, I will. Such kind parting words from both of you. And with that, let's call it a wrap. Thank you.
Bye, everyone.
Bye-bye.
Stay safe. Stay happy.